Thank you, everyone. It's now 10 minutes after the hour, and we will reconvene the meeting to begin oral public comment. I'd like to welcome and thank our public comment speakers today for addressing the committee. All the speakers submitted a request in advance of the meeting, and the final list of public commenters was determined via a lottery. For our speakers, we do have a limited public comment period. In order to make it through all the listed speakers, we ask that you limit your remarks to 3 minutes, and we'll ask my colleagues in the room to please put up the timer. Thank you again to our speakers, and we look forward to your comments. As soon as I see the timer up, we'll be ready to go. Thank you. Our first public comment speaker today is Mrs. Erica DeWald.
Good morning. I'm Erica DeWald, President and founder of Coffee House Communications. Thank you so much for the opportunity to comment today. We hear a lot during these meetings about the need to make sure the schedule can be easily understood by providers. And while this is, of course, important, I think we rarely consider how easy the schedule may be for patients. As many of you know, children who are uninsured are 6 times less likely to be vaccinated than insured children. We also see lower rates of vaccination among children who live in rural areas. While the Vaccines for Children program covers the cost of vaccines, it's clearly not enough to solve all of the access barriers children face. Families living in rural areas and at or below the poverty line have limited opportunities to vaccinate their children. Obviously, in an ideal world, we would have more locations for vaccinations, such as mobile vans or extended clinic hours and time off work for parents to get their children vaccinated. And while we should continue to work toward those goals, in the meantime, there's something that we can control, and that's a streamlined vaccination schedule, particularly for adolescents. The pentavalent meningococcal vaccines are a prime example of the opportunity before you. We can increase vaccination rates against a devastating, unpredictable disease by protecting our adolescents against all strains with a combination vaccine. It doesn't perfectly align with prior recommendations for individual ACYW and B vaccines, but that's why the work group did incredible work to rethink how we protect our children against meningococcal strains. I would respectfully request that all the working groups consider equitable access to vaccines as they form their recommendations. It might also be time to re-examine the schedules in totality to determine if there are ways to streamline recommendations moving forward, particularly as we know more life-saving vaccines and mAbs are going to become available soon. If families can't get to all their vaccine appointments, then it really doesn't matter how well providers understand the schedule. So thank you for all of your hard work and for taking my comments into consideration.
Thank you for your comment. Next, we have Dr. Brian Kaufman.
Thank you to ACIP for this time to talk. I'm Dr. Brian Kaufman, a CLL patient myself, a retired family doctor, and the co-founder, chief medical officer, and executive vice president of the nonprofit CLL Society, dedicated to the unmet needs of those with chronic lymphocytic leukemia. I will be speaking as a physician and a patient advocating for the immunocompromised. As the committee well knows, CLL is a cancer of the B lymphocytes. Its associated immune deficiencies often results in no response or clinically relevant reduction in response to vaccines. This problem is amplified by commonly used therapies, including B-cell depleting monoclonal antibodies. I use CLL as my example as I understand it best, but know that the committee recognizes that CLL is one of many conditions where the diseases themselves or their treatment render patients immunocompromised or immunosuppressed. These include, but are not limited to, other B-cell malignancies, regardless of their treatment status, advanced HIV, congenital immune deficiencies, patients on immunosuppressive drugs to prevent transplant rejections or to treat their cancers, rheumatoid, neurological, or other autoimmune disorders. Some examples specific to CLL patients and vaccines: there is well-documented diminished serological and T-cell response, and much more importantly, diminished protection from hospitalization, ICU admissions, and death with the different COVID-19 vaccines. Responses are known also to be diminished to herpes zoster and hepatitis B vaccines. I respectfully ask ACIP to continue to study the protection provided by all appropriate vaccines in vulnerable communities, and where needed, develop different vaccine protocols as was done with COVID-19. This logically leads to a bigger ask. I ask respectively to ACIP to expand its area of review under its remit to its remit, which is to develop recommendations for U.S. immunization. Immunization, as we know, is not synonymous with vaccination, but rather a broader term meaning to make one resistant to an illness. Please consider advising on pre-exposure prophylaxis, PrEP, with long-acting antibodies, such as those for RSV and COVID-19. These passive immunity approaches are critical to communities like ours, whose members are not reliably able to mount a robust response to the more commonly active immune measures, such as vaccinations. We believe having ACIP advise on all methods of immunization for the most vulnerable could only benefit the immunocompromised community. Thank you for your attention to this important matter for my vulnerable and often invisibly disabled community.
Thank you for your comment. Our next public speaker is Dorit Rice.
Hello, my name is Dorit Rice, and I'm a professor of law in UC Law San Francisco. Thank you again for the chance to comment and for all your work, especially at a time when public health is under pressure and people working to protect others from disease are subject to attack and targeting. I want to say three things. First, thank you for the extensive work you're putting into revising and clarifying the schedule. Dr. Sines opened with it, but I want to re-emphasize, not for the committee, but for others, that the October meeting about the schedule is not to change the schedule, but to update it with that year's recommendations and work on making the schedule more readable before they're published in February. This is not when you add vaccine. I'm saying this because, as you know, this was a point of misinformation a couple of years ago. And thank you for the effort that goes into making the tables easier to read. And I hope the committee in its annual work, given the complexity, continues to put a premium on simple and clear recommendations going forward. Second, in the name of increasing transparency and because of past misinformation, I would suggest that CDC include a short explanation about this in your Who Sets Immunization Schedule page. It currently addresses ACIP's role and the role of experts, but not the technical process. Adding a couple of paragraphs that say CDC updates the immunization schedule once a year, ACIP discusses revision in October, and the updated schedules are published in February, and the October discussion is not where schedules are changed, just when the tables are updated, using, for example, the nice graphic image that Dr. Woodin that excellent presentation included, will not be much work and can help people understand the process better, especially if others try to misrepresent it going forward. Finally, like several others, I'm very excited to have a pentavalent vaccine against meningococcal disease. I know you will be discussing updating the meningococcal vaccine schedules in coming meeting, and I hope you will consider, in addition to protecting our teens and young people and people at risk from this very frightening disease, how to make that schedule easy to understand and accessible. And I have to admit, I have some concerns that yesterday's decision might cause confusion or cause scarcity for practices. For example, I worry that many practices will not carry the new vaccine because of confusion. Thank you for your time.
Thank you for your comment. Our next public comment speaker is Judy Klein.
Good morning. I'm Judy Klein, president of Unity Consortium. Thank you for this opportunity to provide comments and for your ongoing commitment to including perspectives of a wide array of stakeholders. Unity is a nonprofit that unites diverse groups around a common passion, the imperative to protect equitably all adolescents and young adults against vaccine-preventable diseases to support lifelong health. Our vision is for at least 9 in 10 adolescents and young adults to be fully vaccinated on time with recommended vaccines. My comments will reinforce aspects of yesterday's discussions on the use of a new pentavalent meningococcal vaccine and are relevant to ACIP's plans to revisit the adolescent immunization schedule for meninge vaccines. Yesterday, there were observations about the low uptake of MenB vaccines and the challenges healthcare providers face in implementing shared clinical decision-making recommendations. And I'd also add the persistent gaps in coverage among adolescents for other recommended vaccines like HPV, flu, and COVID-19. Unity listens to the perspectives of parents on vaccinating their adolescents so we can better understand their experiences, concerns, and questions. And we conduct routine research with parents and have an established Moms Advisory Council. Last month, our mom advisors talked with us about meningococcal vaccines and the possibility of changes to recommendations and vaccine options for their younger and older teens. The group raised numerous concerns about potential confusion to changes in age recommendations and that such changes may translate into reduced trust or signal mixed messages about recommendations from CDC. The moms wondered that if we have been successful at preventing meningitis disease, why should we change something that is working? Our research indicates, and our mom advisors share, that they trust their adolescents' healthcare provider when it comes to making vaccine decisions for their children. They value provider recommendations that are confident and concise, and this translates into vaccination. ACIP recommendations influence the confidence and decision-making process for parents and the vaccines discussions they have with their providers. Providers, as we know, have limited time during patient visits and may be unable to spend the extra time discussing confusing recommendations. I urge you to approve clear vaccination recommendations that are straightforward to implement and support providers to make confident and concise vaccination recommendations to parents. Unity remains dedicated to working with stakeholders in all sectors to address the challenges of implementing sound and practical recommendations to ensure our adolescents and young adults are protected against vaccine preventable diseases. And we thank you for your tireless efforts to develop these recommendations that guide our providers, families, and individuals. Thank you.
Thank you for your comment. Our next public comment speaker is Dr. Joan Edelstein. I don't see Dr. Edelstein on. So we will come back and check in at the end. Our next public comment speaker is Mr. Noah Luis Ferdinand.
Hi, my name is Noah Luis Ferdinand. I'm the communications coordinator at Voices for Vaccines. Thanks so much for giving me the time to speak today. I just wanted to comment on the way in which information gets shared at these meetings. I've noticed that there is a lot of public discussion and scrutiny as to what gets said here. Almost always after these meetings, we do a lot of work kind of trying to understand, what questions people have about public health recommendations, vaccine recommendations. And I'll see, like screenshots from the slideshows or even little video clips of people speaking here posted online on social media and whatnot. A lot of public discussion of what is very dense scientific information, sometimes understood and interpreted correctly, sometimes not. But even for myself, as somebody who tries to follow along so that I can hopefully explain to other people why a recommendation was made the way that it was, I find I maybe lose some of the key details over the course of, say, 100+ slide presentation. It's just very dense information, and it's science. It has to be. So that's kind of a course, but something that I think would be helpful for me, and I hope for other people, is just a little bit more of an eye towards how communicatable are these recommendations, how intuitive are these recommendations. What would somebody who's not necessarily familiar with this process think about the information presented here? And again, I understand that this is, a scientific discussion, but even like a slide or two, maybe anticipating key questions that somebody might have and responding to those, or, trying to state in plain language some takeaways that you would want the public to have. I think that would go a long way, things like that, towards not only making this information more accessible, but also making it easier to communicate, because at least in my work, I will get questions that are very curious and thoughtful, not just about the vaccines, but the public health process behind the recommendation. I mean, these people sometimes want to know, why was something recommended the way that it was. Good example of this has to do with like the updated vaccine. I think that a lot of people kind of intuitively understand, why somebody who's 65 with a health condition, would want to get that. But then they'll ask, specifically about, their age, or, like I have a 14-year-old daughter, and that stuff is in these presentations. That information is discussed, but it's not always practical or easy to go back and kind of dig that stuff out every time somebody asks kind of questions like that. So anything that can be done to have a little bit more of an eye towards anticipating people's questions, people's concerns, what people are saying already about these meetings that people are paying a lot of attention to, I think would just go a long way towards helping people understand the scientific discussion and getting more out of it. So I very much appreciate what you do here. I don't mean to imply it's opaque, but just maybe something on the side of communication could help a little bit more. So that's all I had to say. Thanks so much for the time, and I will yield the rest of it.
Thank you for your comment. I will return to Dr. Joan Edelstein. Okay, I don't see Dr. Edelstein on. So with that, we will thank our public comment speakers for your willingness to speak today. And we also want to thank those who take the time to submit written public comments via the CDC docket. We will conclude our public comment session and move on to the voting session. So I am going to ask my colleagues in the room to please put up the vote on the table. And Dr. Wody, if you would walk us through if there's anything to read, and my colleagues, if you could put on your cameras, that would be wonderful.
No. Sorry, can you pull out the votes? Let me. Next slide, please. So the proposal is ACIP to approve the recommended child and adolescent immunization schedule, United States 2024, and the recommended adult immunization schedule, United States 2024.
Thank you very much. Are there any questions from committee members? Okay, I don't see any hands raised, so we'll move on to the vote. I'll go in order of my screen today. So Dr. Lair, you're up first.
Jamie Lair, no conflicts, yes.
Thank you. Dr. Bell?
Bell, no conflicts, yes.
Thank you. Ms. Bata?
Bata, no conflicts, yes.
Thank you. Ms. McNally?
McNally, no conflicts, yes.
Thank you. Dr. Long?
Long, no conflict, yes.
Thank you. Dr. Chen?
Wilbur Chen, no conflicts, yes.
Thank you. Dr. Paling?
Paling, no conflict, yes.
Thank you. Dr. Cotton?
Camille Cotton, no conflicts, yes.
Thank you. Dr. Daly?
Matt Daly, no conflicts, yes.
Thank you. Dr. Cineas?
Sybil Cineas, no conflicts, yes.
Thank you. Dr. Sanchez?
Sanchez, no conflict, yes.
Thank you. Dr. Talbot?
Talbot, no conflicts, yes.
Thank you. And Lee, no conflicts, yes. We have 13 yeses and 0 no's. So Dr. Worden, I believe this vote passes.
Yes, Dr. Lee, I concur with your count.
Thank you. Thank you, everyone. Cameras can go off again. And we will move on to the next session, which is on chikungunya vaccine. We will look to Dr. Beth Bell to provide an introduction, who is our work group chair, to provide an introduction and overview of today's session.
Thank you, Dr. Lee, and good morning. Could I have the next slide, please? So just a reminder to the committee and by way of background, we now know that the expected licensure date for Valneva's chikungunya vaccine has been revised from August 2023 to November 2023. There is no chikungunya vaccine ever licensed in the United States or globally, and there are no existing ACIP chikungunya vaccine recommendations. The Chikungunya Vaccines Work Group is developing policy options for ACIP consideration for use of chikungunya vaccine among U.S. persons at risk of chikungunya, including travelers, laboratory workers, and residents of U.S. territories and states with or at risk of transmission. Next. Here's a recap of the previous workgroup presentations to ACIP. In October of 2022, we presented an overview of chikungunya virus disease and vaccines and heard about the immunogenicity and safety of Valneva's chikungunya vaccine. In February of 2023, we discussed the global epidemiology of chikungunya among US travelers, and the issue of persistent arthralgia following chikungunya disease. In June of 2023, we presented some data reporting on the value of a vaccine to US travelers, discussed chikungunya virus infection among laboratory workers, and heard about some observations on a large chikungunya outbreak occurring in Paraguay. Next, please. During today's session, we will present the evidence to recommendations framework for chikungunya vaccine use among US travelers. Dr. Susan Hills will be doing that. And she also will then present an evidence to recommendations, the evidence to recommendations for chikungunya vaccine use among laboratory workers. And I'll just note that there will not be a vote today. The anticipated vote will be at the February 2024 ACIP meeting if the vaccine is licensed in the interim. Next. I want to, as always, thank all of my colleagues on the chikungunya vaccines work group, including ACIP member Dr. Wilbur Chen, CDC lead Susan Hills and Nicole Lindsay, our ex officio members, our ACIP liaisons, and invited consultants who always are extremely pivotal to our deliberations. And next, please. The CDC participants on the chikungunya vaccines work group, including participants from the vector-borne diseases group, from vaccine groups, from the global groups of vaccine safety, and a broad range of other participants across CDC. Next, please. Oh, I guess I don't have another slide. So with this slide up, I will turn the floor over to Dr. Hills. Thank you very much.
Thank you very much, Dr. Bell. Before I present the evidence to recommendations for chikungunya vaccination, I wanted to provide a brief reminder about chikungunya. Chikungunya is caused by chikungunya virus, which is an alpha virus. The mosquitoes that spread the virus to humans are Aedes stegomyia species mosquitoes, primarily Aedes aegypti and Aedes albopictus. And in addition to mosquito-borne transmission, other uncommon modes of chikungunya virus transmission include through exposure to the virus in the laboratory, intrauterine and intrapartum transmission, and blood-borne transmission through needle stick injury. Chikungunya virus occurs in tropical and subtropical regions, as you can see on the map on the right that shows areas with current or past transmission of chikungunya virus. And it has caused large outbreaks throughout most parts of the world. Attack rates in outbreaks are often high, with 1/3 to 3/4 of the population affected. Clinical illness is characterised by the acute onset of fever and polyarthralgia, which is often severe and can be debilitating. Although serious complications can occur, such as neurologic illness, myocarditis, or hepatic or renal disease, they are rare, and mortality is less than 1%. In the absence of specific antiviral treatment, the approach to management typically involves rest, fluids, and use of analgesics and antipyretics. Risk factors for more severe disease include age older than 65 years or under 1 year, underlying medical conditions such as diabetes, cardiac disease, or hypertension, and infection following intrapartum transmission, which can result in neonatal complications, including neurologic or myocardial disease, or dermatologic or hemorrhagic symptoms and signs. The chikungunya vaccine is a live attenuated vaccine and is manufactured by Valneva. It has a single-dose primary schedule, and initial licensure will be for adults aged 18 years and older. The vaccine is currently under consideration by FDA and is not yet licensed anywhere in the world. There are currently no existing vaccine recommendations from ACIP or other vaccine advisory groups around the world. So I'll now discuss the evidence to recommendations for adults who travel abroad to areas with risk for chikungunya virus transmission. I'd like to note that with licensure still pending, any new information at the time of licensure that modifies any of the data or information that I present today might require the ETR to be updated. The policy question is should chikungunya vaccine be recommended for use in persons aged 18 years or older travelling to areas with risk of chikungunya virus transmission? In the first domain of the ETR, the work group addressed the question, is chikungunya of public health importance? We considered 4 key factors. Chikungunya is of public health importance globally, with hundreds of thousands of cases reported annually, and with a particular concern when outbreaks occur because they can have substantial consequences related to morbidity and also impact on health services. However, for US persons travelling to areas with transmission, the risk and therefore public health importance is variable, as transmission varies substantially from location to location and from year to year. Although there is likely substantial underdiagnosis, about 100 to 200 chikungunya cases are reported annually among US travellers. The greatest risk for travellers is when outbreaks occur. In terms of the disease, infection with chikungunya virus can cause an acute illness with arthralgia that can be severe and debilitating, and there is no specific antiviral treatment available. And in addition, the arthralgia can sometimes persist for months or even years. However, overall mortality is less than 1%, and in general, serious outcomes of illness are a more important consideration for some higher risk travellers, such as older persons, particularly those with underlying comorbidities. So the work group's conclusion on public health importance was varies. For the US travelling population, importance varies based on factors including the level of transmission at the destination and individual factors such as the traveller's age and underlying medical conditions. Next, we considered the benefits and harms of chikungunya vaccine, with the result based on the grade assessment. The first question was, how substantial are the desirable anticipated effects? The outcomes we aimed to assess were short and long-term protection from disease. Of note, there were no efficacy data, and this approach for vaccine licensure would have been logistically very challenging because outbreaks are unpredictable and their duration can be relatively short. In the absence of efficacy data, we reviewed immunogenicity data. However, there is no correlate of protection. In considering the data, we noted that the approach being used for licensure of the vaccine is through the accelerated approval pathway. With this approach, demonstration of effectiveness is based on clinical trials showing the vaccine has an effect on a surrogate endpoint that is reasonably likely to predict clinical benefit. There is a post-licensure requirement for vaccine effectiveness studies to confirm the clinical benefit. In the clinical trials, the marker of protection used was based on a neutralising antibody titer estimated from a validated non-human primate model. There were 2 studies providing evidence for short-term protection from disease after vaccination, one randomised controlled trial and one lot-to-lot consistency study that did not include a placebo group. There were a total of 622 subjects in the 2 studies, and the seroresponse at 28 days after vaccination was at least 98% in both studies. None of the 96 subjects in the placebo arm of the randomised controlled trial had a seroresponse. The evidence used to evaluate long-term protection after vaccination was from one study which included 360 subjects. At 12 months after a single dose of vaccine, a seroresponse was detected in 99% of subjects. Based on these data, we considered the desirable anticipated effects were large. The next question was, how substantial are the undesirable anticipated effects? And for this question, the work group considered that the critical outcomes were serious adverse events, arthralgia, and arthritis. In regards to serious adverse events, in 2 clinical trials, 1.5% of 3,490 vaccinated subjects reported serious adverse events. In the 1 randomised controlled trial, 0.8% of placebo recipients reported serious adverse events, and this was not a statistically significant different percentage from the 1.5% of subjects in the vaccinated group with SAEs. Among all the SAEs, 2 were considered probably vaccine-related by study investigators. They included severe myalgia beginning 1 day after vaccination in a 58-year-old woman with a history of fibromyalgia. She was admitted to hospital for pain management and diagnostic procedures. The second was a hospitalisation of a 66-year-old man for a serious adverse event beginning 3 days after vaccination of myalgia, high fever, syndrome of inappropriate antidiuretic hormone excretion, and atrial fibrillation. The second outcome of interest was arthralgia and arthritis. Arthralgia is a key feature of clinical illness with chikungunya virus infection, and the vaccine is a live attenuated vaccine, so the work group closely investigated outcomes of arthralgia or arthritis after vaccination. The manufacturer provided data from 2 studies, but for simplicity today, I'll present the results of the randomised placebo-controlled trial. The second study was a lot-to-lot consistency study with 408 vaccinated subjects, but without a placebo group. The percentages of each adverse event were similar in vaccinated subjects in both studies. Overall, 17% of subjects reported any arthralgia as a solicited adverse event within 10 days of vaccination. This percentage was significantly higher than the rate of 5% reported in the placebo arm. Severe arthralgia, which was defined in the studies as an event that prevented daily activity, occurred in 0.3% of vaccinated subjects and no subjects in the placebo arm, and this difference was not significantly different. Persistent arthralgia, defined as arthralgia commencing within 10 days of vaccination and with duration longer than 15 days, was present in 0.3% of subjects, which was again not significantly different from the percentage with this outcome in the placebo group. And finally, arthritis and osteoarthritis were collected as unsolicited adverse events and were reported at rates of 0.2% and 0.4% in the vaccinated group respectively. Both rates were again not significantly different in the control group. So overall, for these 5 outcomes, the only event where an arthralgia or arthritis outcome was reported at a significantly higher rate in the vaccinated group compared with the placebo group was any arthralgia within 10 days of vaccination. However, in assessing these outcomes, the work group noted that the number of subjects included in the studies was too low to adequately assess potentially rare events like severe or persistent arthralgia, arthritis, or new onset or worsening osteoarthritis. Based on these results on serious adverse events, arthralgia and arthritis, we considered the undesirable anticipated effects of vaccination were small. We then considered the question, do the desirable effects outweigh the undesirable effects? The work group noted that there were high seroresponse rates through at least 1 year after vaccination and no serious safety concerns identified in the clinical trials that have been performed to date. That included approximately 3,500 vaccinated individuals. In addition, vaccination can prevent a disease that can result in severe arthralgia during acute illness, rare serious complications, and sometimes long-term arthralgia. However, we noted that healthcare providers should discuss the desirable and undesirable effects with individual travellers in the context of the disease risk at their destination, their activities, and personal factors such as age and underlying medical conditions. As with any vaccine, rare serious adverse events can occur, and for some travellers, even a low probability of a serious adverse event might be higher than their disease risk. So vaccination should be targeted to travellers at higher risks for disease. Overall, the workgroup determined that the risk-benefit assessment will vary substantially and inversely with transmission intensity and other factors, and is favourable if the vaccine is used in line with our proposed recommendations. Finally, we considered the grade assessment results to determine the overall certainty of the evidence for the critical outcomes. The overall certainty of evidence for short-term and long-term protection after vaccination was low. Certainty was downgraded based on very serious indirectness because the likelihood of protection from disease was based on immunogenicity data in the absence of vaccine efficacy data. There's no established correlate of protection, and demonstration of effectiveness for vaccine licensure was based on a surrogate endpoint reasonably likely to predict clinical benefit, and results will require post-licensure vaccine effectiveness studies to confirm the results. The overall certainty of the evidence for serious adverse events and arthralgia arthritis was low. Certainty was downgraded for individual safety outcomes because of various serious imprecision related to the small sample size, because the confidence interval around the effect estimates indicated the potential for possible benefit or harm from vaccination, or because of indirectness related to a suboptimal method for collection of specific outcome information. Although we assume results will be similar when the vaccine is used in larger populations, real-world data would be important to confirm the safety profile available from the clinical trials. For Domain 3, values, 2 studies informed the workgroup's response on the extent to which the target population feels the desirable effects of vaccination are large relative to undesirable effects, and if there is important variability in how much people value the main outcomes. The first study was an online study conducted in 2022 with questions prepared by CDC staff and which considered perceptions of a chikungunya vaccine among US adults. Participants were provided with information on risk for disease with travel during outbreak or non-outbreak periods, rates of chronic arthralgia after disease, and a hypothetical vaccine cost. Results showed that during an outbreak period, defined as a traveller having a 1 in 150 risk of disease, the likelihood respondents would receive the vaccine was very or somewhat likely in 42%, shown in green, very or somewhat unlikely in 32%, shown in blue, and unsure in 26% in grey. During a non-outbreak period, defined as a risk of disease of 1 in 15,000, the likelihood respondents would receive the vaccine was very or somewhat likely in 27%, very or somewhat unlikely in 49%, and unsure in 24%. There was variability in responses with a lower likelihood of vaccination among persons aged 18 to 29 years compared with adults in older age groups, among those with lower education and household income levels, and people of black race were less likely to be interested in being vaccinated than those in other race or ethnicity groups. Consistent with results for the high and low risk scenarios, the most important factor considered by respondents in making a decision on vaccination was the risk of disease. Also important for many respondents were the risk of vaccine side effects, the chance to avoid possible long-term joint pain through being vaccinated, and vaccine cost. The second study was an online survey funded by the vaccine manufacturer and conducted in 2021 among approximately 2,000 US residents aged 18 years and older who had travelled internationally during the last 3 years or plan to do so within the next 3 years. Limited information about participants was provided, but anyone who self-identified as anti-vaccination was excluded. After being provided basic information on chikungunya and its sequelae, 72% were very or somewhat likely to ask a healthcare provider about a vaccine, and 80% were very or somewhat likely to be vaccinated if the vaccine was recommended by a healthcare provider. Although there were substantial limitations of both of these studies, overall the work group determined that it is likely US travellers will have variable opinions on whether the desirable effects of vaccination are large relative to the undesirable effects. And there will likely be important variability in how much people value the vaccine, with level of disease risk a key factor in determining likelihood of vaccination. The work group noted that clinicians should allow for discussion of individual values and preferences in their discussions on vaccination against chikungunya. Domain 4 was on acceptability of chikungunya vaccine. In considering acceptability, the work group thought that key stakeholders were US travel medicine and other healthcare providers and travellers. In regards to travel medicine and other healthcare providers, an online survey in 2021 funded by the vaccine manufacturer and conducted among 158 US healthcare providers who routinely provide travel health services found that 80% were very or somewhat likely to recommend the vaccine if it was recommended by ACIP. For travellers, vaccine recommendations are expected to be acceptable because vaccine availability gives an option, in addition to mosquito bite prevention measures, for protection from a disease that can cause severe arthralgia and potentially long-term joint pain. The work group therefore thought the intervention would be acceptable to key stakeholders. In Domain 5, the work group considered if chikungunya vaccination is a reasonable and efficient allocation of resources. A cost-effectiveness analysis for chikungunya vaccination of travellers has not been conducted. Most travel vaccines are not cost-effective, and chikungunya vaccine for travellers is not likely to be cost-effective because the number of US travellers needed to be vaccinated to prevent one case is high. However, the work group noted that cost-effectiveness considerations are less relevant for a travel vaccine because the decision on vaccination is for an individual traveller and not being made for the population, so broad resource allocation decisions are not being made. And because the vaccine is typically paid for by the traveller themselves and is often not covered by insurance. The work group also noted vaccine recommendations targeted to higher risk groups are probably an efficient use of resources, as the financial implications of vaccine purchase will be borne by travellers most at risk of a disease or severe outcomes, who will therefore receive the most benefit. The work group therefore determined that chikungunya vaccination is probably a reasonable and efficient allocation of resources if chikungunya vaccine recommendations are targeted to higher risk groups. In Domain 6, we considered the impact on health equity. Chikungunya vaccine will probably have to be paid for out of pocket by most travellers, and some travellers will have resources to pay for vaccine and others will not. In addition, travel medicine providers are likely to have a better awareness of chikungunya disease and vaccine availability than non-specialist providers, but people with fewer resources are less likely to attend a specialist travel medicine provider. These issues might cause health disparities, but the work group noted that the chikungunya vaccine recommendations cannot address these issues. The work group's conclusion was that health equity would probably be reduced by chikungunya vaccine availability, but the issue cannot be addressed within the context of the vaccine recommendations. For the final domain, we considered the feasibility of implementation of chikungunya vaccination. The work group noted the vaccine has a single-dose primary series, which should allow for easy administration during a pre-travel consultation. One topic the work group discussed was that disease risk is highest during outbreaks, and vaccination will be of most benefit for travellers during an outbreak. However, a challenge might be a delay in awareness of an outbreak, with travellers potentially exposed during high-risk periods in the early stages of an outbreak. To address this as best as possible, CDC will post information on outbreaks on the CDC website as soon as we become aware of outbreaks. Although we discussed this as a challenge, most of the work group members did not think it would be appropriate to address the issue by recommending vaccination to every traveller travelling to any destination with risk of chikungunya, because there would likely be an adverse risk-benefit assessment given the variable and often very low risk for travellers, and because of the substantial differential between risk during outbreaks and at other times. The decision overall was that vaccination is probably feasible to implement. Overall, when considering all the domains of the evidence to recommendations framework, the work group determined that the desirable consequences probably outweigh the undesirable consequences in most settings. And now I'll present the draft recommendations prepared by the work group for ACIP's consideration. Our draft recommendations for the live attenuated vaccine currently under consideration by the FDA for licensure are that chikungunya vaccine is recommended for persons aged 18 years and older travelling to a country or territory where there is a chikungunya outbreak. In addition, chikungunya vaccine may be considered for the following persons travelling to a country or territory without an outbreak, but with evidence of chikungunya virus transmission among humans within the last 5 years. The groups are older persons, for example, older than 65 years, particularly those with underlying medical conditions who are likely to have at least moderate exposure to mosquitoes, and persons staying for a cumulative period of 6 months or more during a 2-year period. To provide data to support our primary recommendation for vaccination for persons travelling to a location where there is a chikungunya outbreak, I'll provide an example from US traveller chikungunya data from 2023. As you might recall from a presentation I gave at the June ACIP meeting, there was a large outbreak of chikungunya in Paraguay during 2023. On the left, you'll see a graph that shows that among all US travellers to destinations with risk of chikungunya, fewer than 1% travel to Paraguay. However, on the graph on the right, you will see that among all US traveller chikungunya cases reported to date during 2023, 26% of them, or 18 of 69 cases, have been among persons who travelled to Paraguay. These data clearly demonstrate the substantially higher risk for travellers during an outbreak. To clarify what is meant by an outbreak in the language of the recommendations, an outbreak will be defined as occurring when CDC posts information on an outbreak on the CDC website. As I noted earlier, a notice will be posted as soon as CDC becomes aware of an outbreak. A similar process is used for cholera and in relation to the cholera vaccine recommendations, with information posted when cholera outbreaks occur. I also wanted to provide some additional explanation about the second part of our recommendations, or the shared clinical decision-making component. And as a reminder, this is chikungunya vaccine may be considered for the following persons travelling to a country or territory without an outbreak, but with evidence of chikungunya virus transmission among humans within the last 5 years. Older persons, for example, older than 65 years, particularly those with underlying medical conditions who are likely to have at least moderate exposure to mosquitoes, and persons staying for a cumulative period of 6 months or more during a 2-year period. For these groups, there is definitely more uncertainty in the risk-benefit assessment. However, there are likely to be circumstances when some individuals might reasonably choose vaccination, or some providers might wish to recommend it. I'd like to explain the workgroup deliberations around noting older persons, particularly those with underlying medical conditions, should be considered for vaccination, and to provide some data supporting the inclusion of this group. Among adults, the key risk factors for severe chikungunya disease are older age and underlying medical conditions. Similarly, for chronic arthralgia, risk factors include older age and the presence of pre-existing joint problems, which is more likely in older persons. The risk for higher morbidity and mortality in older persons is supported by data from the recent outbreak in Paraguay. Although overall risk for hospitalisation and death from chikungunya is low, there is a markedly higher risk for older persons. The graph shows data by age group with the number of hospitalisations in the blue bars and the case fatality rate in the dark blue line. The data clearly point to the higher risk for hospitalisation and death in those over 65 years. The work group did discuss a broader recommendation for vaccination for any adult with a medical condition. However, with more than 50% of the US adult population having an important medical condition, such as hypertension, diabetes, or heart disease, that would be a very large population for a recommendation. And in relation to that, we discussed the importance of having additional data from post-marketing surveillance to confirm the vaccine safety profile. Therefore, most work group members thought the best approach was to restrict our recommendation in a non-outbreak setting when risk is often low to those over 65 years of age, particularly those with underlying medical conditions. The second group, noted as a group for consideration of vaccination based on shared clinical decision-making, is travellers who have a cumulative period of travel of 6 months or more during a 2-year period. The key risk factor for chikungunya virus infection among travellers is the intensity of transmission, far more so than the duration of travel. However, if there is equivalent transmission in different areas, then the cumulative duration of exposure becomes important. Additionally, even though a destination might be a low-risk environment overall, transmission patterns can be unpredictable over the longer term, and over a 6-month period, there is likely to be some seasonal variation in mosquito activity that might impact risk. Therefore, the work group considered a shared clinical decision-making recommendation for this group also was appropriate. The 2-year period is based on immunogenicity data showing a high seroresponse rate of 99% at 1 year after vaccination, which suggests there should be good protection from vaccination at least through the 2nd year, but we do not have any longer-term data at the current time. I would also like to explain why the recommendation refers to evidence of chikungunya virus transmission among humans within the last 5 years. The rationale for the timeframe is that given the challenges and deficiencies in surveillance, a 5-year timeframe provides an interval that allows reasonable confidence that there is transmission in a certain location, or conversely, that there is insufficient transmission for there to be a concern for travellers. The tool to provide this information will be a map which shows countries with reported chikungunya virus transmission among humans during the last 5 years, which will be posted on the CDC website. And a mock-up example is provided there on the slide. To describe one final point, the recommendation refers to moderate exposure. Text will be provided within the recommendations that indicates moderate exposure could include travellers who might have at least 2 weeks cumulative of exposure to mosquitoes in indoor or outdoor settings. And it does not include travellers who might have limited exposure to mosquitoes. For example, those travelling for business and likely to be mainly in mosquito-protected indoor settings. In conjunction with the recommendations, there will also be language noting travellers should use mosquito bite precautions, and also text in a table outlining the factors that need to be considered in the healthcare provider and traveller discussion about chikungunya vaccination. I won't read this text, but it was provided in the background materials. So these are our complete recommendations for ACIP's consideration, and I will hand back to Dr. Lee.
Thank you very much, Dr. Hills. This presentation is now open for questions. Dr. Paling.
So first of all, let me just say thank you. This vaccine's never been reviewed, and this is enormous amounts of work. And when people do get chikungunya, they get very sick. And so I recognize the importance of this vaccine. I also really appreciated the explanation of the morbidity and mortality with this illness with age. My question is a request to be reminded about the clinical trials. Can you remind us of the age groups that were included in those clinical trials? Thank you.
Yes, thank you for that question, Dr. Paling. So for the randomized control trial, the age groups included persons from 18 years to over 65 years. I think 91 was the oldest. In the immunogenicity subset, there were 59 subjects in over 65 years of age in the randomized control trial. In the lot-to-lot consistency study was among persons aged 18 to 45 years, I believe.
Thank you. I just wanted to make sure we had data on the immunogenicity of the elderly, and I feel reassured with that. Thank you.
Thank you, Dr. Cotton.
So I just want to be clear, for immunocompromised, this is a attenuated but replicating virus, so similar to measles, yellow fever, varicella. That's correct, right?
It's a live attenuated vaccine, and we anticipate immunocompromise will be a contraindication to vaccination.
Okay. Along those lines, I guess if we're going to recommend it for older persons, it looks like there weren't that many people in the over 65 cohort, and I do have some safety concerns about a replicating virus, especially as we age. We have, diminished ability to clear viruses and whatnot. So I guess I have some concerns about whether we should make that recommendation. Maybe we should review the data on people over the age of 65. It looks like maybe there were just 59 in perhaps the trial you're mentioning. So before we make a recommendation, we might want to just look hard at that safety data. It looks like there were no significant safety concerns, but I have concerns. Certainly we've learned a lot during the COVID-19 pandemic. I've learned a lot about immunocompromised people in their 70s and 80s, and that the immune system wanes with age. So I just have some safety concerns. Thank you.
Thank you very much for that question. Could I have slide 83, please? Thank you. Yes, indeed, that's an important question, and the work group did consider that very closely. This graph shows data by age group with a percentage of subjects with arthralgia represented by the height of the bars and the severity illustrated by the colours, blue's mild, grey's moderate, pink severe. And the rate of arthralgia and the severity of arthralgia after vaccination didn't increase with age. However, it is an important point, and we will be interested with the FDA assessment when it's licensed, as well as ongoing monitoring safety of the vaccine. Thank you.
Thank you. That's a very nice slide, and actually shows a good number of people in the 65 and older cohort. So thank you very much.
Thank you. Dr. Daly?
Yeah, two quick questions. One was a follow-up question from what Dr. Cotton asked. So I was going to ask a similar question, but related. What's known about clearance in natural infection, and what's known about clearance in vaccination? And is sort of persistence of infection related to arthralgia? And then I have a second question.
Yeah, so the virus is cleared fairly rapidly. In relation to the arthralgia, it's not definitively determined, but it's believed it's more an immunologic issue. There has been situations where RNA has been detected in the synovial fluid, longer term, but in general, it's considered it's probably more an immunologic response rather than persistent. It's a virus.
Okay, thanks. And then could you put up the draft recommendations just for clarification?
Can I have slide 67, please?
So I'm assuming that there's an or between the second bullets, meaning age over 65 or 6 months.
Thank you for that clarification. We'll add that.
That's true. Okay, thanks. Bye.
Thank you. Ms. McNally.
I have two questions. What is treatment for chikungunya? And my second question is, do we have any information about the cost of this vaccine? Thank you.
So there is no treatment for chikungunya, no specific antiviral treatment for chikungunya. So management is typically with fluids, rest, use of medications for fever and for pain. We do not have information on cost of the vaccine at this time.
Thank you. Dr. Sineas?
Yes, thank you. Given that this vaccine will likely be administered as part of a visit to a travel clinic, do you have any data or information on co-administration with other travel vaccines?
There have been no studies done to look at co-administration with other vaccines.
Well, sorry, just to clarify then, do you believe the guidance will remain silent about it, or do you?
Yes, there are no data, so we will just be indicating there are no data.
Okay, thank you. Dr. Cotton.
I guess I would just clarify in that first bullet point about older persons with underlying medical conditions, and I would have some kind of phrasing about making sure they're not immunocompromised, just to make it really obvious. We see all kinds of live viral vaccines being given to people that we wish had not received them. Thank you.
Thank you. Dr. Long?
Yes, it's a typical question here. We're going to say particularly want to give it to those over 65, particularly with underlying medical conditions. Although I think you showed us the immunogenicity data, you, I think, told us that those were much younger people. So will there be any immunogenicity data in older than 65 and with underlying conditions, so that we'll know that it is as immunogenic in that group?
Thank you for that question. So the data in older 65-year-old, the immunogenicity data that have been gathered to date do include subjects up to about 90 years of age. There's about 60 subjects where those data have been collected for immunogenicity. They were typically healthy for inclusion in the clinical trial, or didn't have any serious underlying medical conditions.
Dr. Bell?
Yes, I just, if it's all right with you, Dr. Lee, I think that someone from Valneva might be on the phone, and there have been a couple of issues that they might want to comment on, including the potential cost of the vaccine and this last question that was just asked about additional data in older adults.
Thank you. Please go ahead.
This is Ellen Shannon from Valneva. I can comment on the price question. We do expect that the price of the vaccine will be in line with the other travel vaccines on the market. And there was a second question. I'll refer to my colleague Katrine Dubachar specifically about data in older adults. Was that?
For the chikungunya vaccine at Valneva, we have actually generated some additional immunogenicity data in older adults where the sample goes up to roughly above 100. We continue to see very high seroresponse rates that do not differ from younger adults. And in terms of the population that was studied, I can just support the answer that Dr. Hills gave, that the study population was a generally healthy adult population, but we included also participants with underlying diseases for as long as those were stable and controlled. Thank you.
Thank you. Dr. Paling?
First of all, thank you to Valneva. There are people on this call that do not give travel vaccines on a routine basis. And so it would be really helpful if you would be willing to share a price range. Thank you.
This is Ellen Shannon from Valneva. We are going to be in line with a previous presentation by Dr. Hills. She had presented to the ACIP in June, and it was in the range of her analysis, approximately $350 cost to the patient, or in that vicinity, slightly less.
Thank you. Are there any additional questions? Okay, why don't we move on to the next presentation, also Dr. Hills, regarding the evidence to recommendations and proposed policy options for chikungunya vaccine use among laboratory workers.
Thank you very much, Dr. Lee. So I'm again going to start with a brief reminder of general considerations for laboratory transmission of chikungunya virus before starting on the evidence to recommendations for chikungunya vaccine use among laboratory workers. At least 44 cases of chikungunya virus infection in laboratory workers have been reported worldwide during the last 50 years. 43 were cases of overt disease, 1 was an asymptomatic infection, and there were no deaths. In regards to US laboratorians, 4 disease cases have been notified in the 8-year period since chikungunya became a nationally notifiable disease in the United States in 2015. However, the identified cases likely underrepresent all infections in laboratory workers, as there is no formal laboratory surveillance system for reporting these events. Documented routes of transmission of chikungunya virus in the laboratory have been through the aerosol route and the percutaneous route. Among cases of percutaneous transmission with more detailed information available, 2 researchers experienced a needle stick injury while they were working with and injecting mice, and for a 3rd case, a researcher experienced a forceps prick while dissecting mosquitoes infected with chikungunya virus. Transmission through accidental mucosal exposure is also possible. The policy question the workgroup considered was, should chikungunya vaccine be recommended for laboratory staff at risk for chikungunya virus infection? I'll note that the same grade assessment for outcomes of vaccination was used for laboratory workers as was used for travellers, so I won't present the grade results again. However, when discussing laboratory worker recommendations, the workgroup did specifically discuss the topic of cross-protection provided by vaccination against the 3 genotypes of chikungunya virus, given laboratory workers might be exposed to high titers of a specific genotype. We noted there are only very limited data from laboratory studies to confirm cross-protection. However, we also noted that although there are multiple genotypes of chikungunya virus, they are generally considered to constitute a single serotype, and the differences in antigenicity are relatively limited. There is also no evidence of reinfection in humans with different genotypes. For the first domain of the ETR, the workgroup determined that chikungunya can't be considered of public health importance overall, as there are only occasional cases reported among US laboratory workers. However, for laboratorians working with the virus, there is the potential for acute infection with severe polyarthralgia and the possibility of chronic arthralgia. For values, we considered that scientists are likely to consider the desirable effects of vaccination are large relative to the undesirable effects, and there is unlikely to be important variability because they will likely understand the risks of disease and risks and benefits of vaccination, and most scientists value vaccination. Chikungunya vaccine is likely to be acceptable to key stakeholders, including occupational health directors, laboratory managers, and laboratorians, as its availability will improve laboratory safety. For resource use, the workgroup felt that chikungunya vaccination was a reasonable allocation of resources because vaccination recommendations will be for a limited number of staff undertaking research or specific diagnostic work. And paying for vaccination is a small cost for administrators to pay to avoid the substantial impact and costs of a worker becoming infected. We thought that equity would probably be increased because if employers offer chikungunya vaccination to laboratory staff, it will improve safety for workers and address an occupational health issue. And finally, we thought that vaccination was feasible to implement as it will likely be incorporated into existing occupational health programs for laboratory workers. Overall, when considering all the domains of the evidence to recommendations framework, the work group determined that for chikungunya vaccination for laboratory workers, the desirable consequences probably outweigh the undesirable consequences in most settings. And our draft recommendation for ACIP members' consideration is chikungunya vaccination is recommended for laboratory workers with a potential for exposure to chikungunya virus. The recommendations will be presented with additional text to provide clear information for implementation, including noting that a local institutional biosafety committee should undertake a risk assessment of the potential for exposure to chikungunya virus for each laboratory worker working with the virus, considering the type of work to be performed and the biosafety level at which work will be conducted, and that vaccination is not necessary for workers handling routine clinical samples who should routinely use standard practices for handling patient samples. So again, our draft recommendation is chikungunya vaccination is recommended for laboratory workers with potential for exposure to chikungunya virus. And I will hand back to Dr. Lee for any questions.
Thank you. Dr. Grog?
Yeah, this is Stan Grog, and I've got a travel medicine certificate from ISTM. But we take mission teams to different areas of the world. In the 6-month time period, I didn't get my hand up in time, but the 6-month time period seems a little bit unusual. It only takes one mosquito bite to give you chikungunya, and I've seen chikungunya in a lot of areas, Haiti and Nicaragua, that again, 6 months, I think it should have been expressed more if you're out in the countryside for any particular short time period, you could be exposed to chikungunya pretty easily. Thank you.
Yes, thank you for that question. So you're correct that it takes just one mosquito bite, but it needs to be an infected mosquito. And what we do see is that there are millions of travellers to areas with the risk for chikungunya virus transmission each year. And we really only see 100 to 200, as I said, reported cases. This year, we've seen about 70 cases of chikungunya virus transmission. So when the work group had these discussions, we were really trying to weigh up the benefits of vaccination with the benefits in terms of protection from disease with the risk-benefit assessment in terms of the risks and need for vaccination. We wanted to provide a time period to provide fairly clear advice for healthcare providers, unlike you, Dr. Grog, who has a certificate from the ICM. A lot of healthcare providers are not familiar with chikungunya virus. In fact, in a survey that the manufacturer did, only 50% of travel medicine providers were described themselves as familiar with chikungunya. So we're trying to weigh up that, and we didn't really want to specify the location either, just because the Aedes aegypti mosquito is a very domestic mosquito, so it can be found around homes. It breeds in containers like flower, the base vases, the base of flower pots in trash that's lying around. So it can be very high intensity in urban areas, unlike some of our other diseases like Japanese encephalitis, for example, that are more risk in rural areas. So yeah, that's sort of the thinking the work group went through to get to our traveller recommendations.
Thank you.
Thank you. Dr. Paling?
So thank you for this presentation, and thank you. I agree with you that having this option for laboratorians that work with this virus makes sense. A clarification that would help me understand the feasibility and equity is when a vaccine is recommended for occupational health, these people that are exposed, is it covered by the employer, or does the employee have to cover the expense of this vaccine? Thank you.
Thank you, Dr. Paling. As I understand it, in many, if not most cases, it is covered by the employer. So CDC, for example, pays for the vaccine. We do have a member on our work group who does work in a research facility that uses a vaccine, and I understand they pay for the vaccine. I can't definitively comment on every institution, but I do believe most places will pay for it.
Thank you. Dr. Cotton?
For this language, I was wondering if we should put in front of laboratory workers non-immunocompromised. I don't know if that's appropriate or if it would just be in the fine print, but I would want to emphasize, you know, an estimated 3% of the US population is immunocompromised, and you wouldn't want someone to accidentally get this. Thank you.
Thank you, Dr. Cotton. I will note that there will be in the MMWR a very clear section that has the contraindications. We are waiting for the FDA's licensure of the vaccine just to confirm what they are, but certainly it's an important point with a live attenuated vaccine.
Thank you. Are there any additional questions for Dr. Hills? And particularly if any members would like to make a comment about the recommendation language for the next meeting. Dr. Talbot.
Yeah, I just was hoping for clarification about coverage, because we had this large discussion for rabies, and techs who worked in veterinary offices did not have their rabies vaccines covered. And that was one of the issues we had with the vaccine. So I'm not sure how this is different. And it does make me worry that it needs to be covered by employees.
Dr. Hills, I'm going to ask to see if somebody from SHEA is on. Is Dr. Marotra on still? Okay. Dr. Hills, sorry, I apologize for interrupting. Is there, I don't know if you have any additional response in terms of, I don't believe ACIP directs the coverage of employers, but if there's any additional information you can provide, that would be helpful.
Yeah, thank you, Dr. Lee. I do not have any additional information. I don't think we can address that in the context of our recommendations, but definitely is an important point, and it will clearly be indicated that it is recommended for people who are at risk for potential exposure, but I cannot directly address the question on payment.
Thank you. Dr. Cotton?
I'd just like to second Dr. Talbot's point. This is an area, laboratory workers, especially microbiology workers, that has really been decimated from the pandemic. Staffing issues are quite significant. So I'd like to just lend support for advocacy in protecting them with vaccines that hopefully could be covered optimally by their workplace or other modalities. I don't know if there would be a program for vaccination of laboratory workers, but something along those lines, because it really is a vulnerable population, and many of us are really suffering by the short staffing in those areas, and many of our patients are impacted by that. So if we could better protect them, we could perhaps better protect American healthcare. Thank you.
Thank you for that comment. It definitely is an important issue.
Dr. Hills, as a way to follow up on that, are there any, I recall surveys in the past just to understand what the practices were, but would there be opportunity for any planned surveys to understand coverage, just to monitor whether or not there are any access and equity issues, essentially?
Yeah, thank you for that suggestion, Dr. Lee. It's not an area I'm familiar with, but we can certainly look into it further and see if there is any information available.
Thank you. Yeah, or any surveillance systems or anything that might be able to shed light into whether or not adoption is happening in the future. Well, with that, I just want to thank you, Dr. Hills, for the tremendous amount of work you just presented and very efficiently, and Dr. Bell also for your presentations on chikungunya vaccine. We will move on next to a brief update, I believe, by Dr. Wilbur Chen, who is the work group chair for dengue vaccines. Dr. Chen, I don't know if you have slides, but if you have a dengue vaccine update for us, we'd appreciate it.
Yes, and I believe my slides are up. So let's go to the next slide. So let me just remind you that dengue presents a significant public health problem to areas that suffer from the burden of endemic dengue. And dengue is endemic in United States territories like Puerto Rico, Virgin Islands, American Samoa. But it's not endemic to the continental US. Next slide. So Dengue Vaccine, which is manufactured by Sanofi Pasteur, was the first dengue vaccine licensed by the FDA. It was approved in May 1st, 2019. The ACIP developed recommendations for Dengue Vaccine in June of 2021. You can see the recommendation language there on the slide. I won't read it myself. Next slide. So Takeda had a dengue vaccine candidate, TAC-003. It was the second vaccine that was under review by our work group. It's been in review since August of 2022. The dengue work group presented to the ACIP on 3 different occasions: October 2022, February, and June of this year, 2023. In October 2022, we reviewed the dengue epidemiology and reviewed the Sanofi dengue vaccine, and then the ACIP recommendations that had been approved. In February of this year, Takeda presented their data on the safety and efficacy of the vaccine, and the work group also provided a summary and an interpretation of the data that was presented. Then in June 2023, the policy questions, economic and cost-effectiveness analyses, and a partial evidence to recommendations framework were presented. And for today's meeting, we had intended originally to present the draft recommendations and full evidence to recommendations framework. Next slide. So I'll just remind you, there was a pivotal efficacy study. It was a phase 3 TIDES trial. It was designed for the primary endpoint for virologically confirmed dengue, or VCD. Among seropositives, you can see there is protection that is documented for all 4 serotypes of dengue, for both VCD, but also for another endpoint for hospitalization, a more severe endpoint. Next slide. Now let's look at the seronegatives. Among seronegatives, protection is demonstrated against serotypes 1 and 2. You can see there in the box. Next slide. But then when you look at the seronegatives, there's no efficacy that we documented against serotypes 3 and 4. The data were insufficient to rule out increased risk of VCD among vaccinees, in fact, because of the very low numbers of events. Next slide. When evaluating hospitalizations as an outcome, the more severe measure, among seronegatives, there were low numbers of events. Efficacy was not demonstrated for serotype 3, and there was only a single hospitalization event for dengue serotype 4, so efficacy is really not known. Next slide. So if you look at the global stage, the European Medicines Agency, in cooperation with the World Health Organization, they provide reviews for markets outside of the European Union, and it's a procedure that they call the EU Medicines for All, or the EU M for All. On October 14th, 2022, the Committee for Medicinal Products for Human Use, CHMP, of the EMA provided a positive opinion, and they recommended the approval of TAC-003 for the prevention of dengue disease caused by any serotype in individuals 4 years of age and older in Europe and in dengue endemic countries participating in this EU M4A procedure. December 8th, 2022, the European Commission granted marketing authorization for TAK-003, and thereafter its trade name is Qdengue. And since then, TAK-003 has been approved in the EU, UK, and Brazil, Argentina, Indonesia, and Thailand as well. Next slide. So here in the US, July 11th, 2023, Takeda announced that they voluntarily withdrew its biologics license application from the FDA. Their reason was that the FDA had requested for additional data, which was not collected in the pivotal efficacy study, the phase 3 TIDES trial that I showed you in earlier slides. Next slide. Meanwhile, the WHO SAGE Strategic Advisory Group of Experts on Immunization in September developed recommendations and recommended that TAK-003 be considered for introduction in settings with high dengue disease burden and high transmission intensity to maximize the public health impact and minimize any potential risk to seronegative persons. SAGE also recommended that the vaccine be introduced to children aged 6 to 16 years of age, and within this age range, the vaccine should be introduced 1 to 2 years prior to the age-specific peak incidence of dengue-related hospitalizations. So that's just kind of when it should be launched in those populations. The vaccine should be administered in a 2-dose schedule with a 3-month interval between the 2 doses. SAGE recommended that vaccine introduction be accompanied with a well-designed communication strategy and community engagement, which is important for all dengue vaccines to be launched. And then they also recommended post-authorization studies should be conducted to further study vaccine effectiveness and safety against serotypes 3 and 4. Okay, next slide. So the future plan for TAK-003 in the US is going to be further evaluated by Takeda, but as of now, the ACIP dengue vaccine work group will be paused until the BLA for TAK-003 is resubmitted to the FDA or a new dengue vaccine is submitted to the FDA review for the work group to consider. Next slide. So I really wanted to tell you about this pause in our work group. I also wanted to take this opportunity to thank the work group CDC leads, Drs. Gabriela Paz-Bailey and Laura Adams. I also wanted to thank the many CDC contributors, our consultants who have been just tremendous in giving us their opinions, the ex officio members, liaison representatives, and certainly my co-ACIP members who have provided their service and contributions to this work group. Thanks very much.
Thank you very much, Dr. Chen. Are there any questions for Dr. Chen or other work group members? Dr. Long?
I wonder if you can tell us if the uptake of the previously recommended vaccine for 9-year-olds who are seropositive has increased from what was woeful infrequent?
So I think I can direct that question to Dr. Paz-Bailey, who could perhaps tell us about the rollout in Puerto Rico.
Yes, Dr. Chen, can you hear me?
Yes, we hear you well.
Thank you. Yeah, implementation of Dengvaxia has been complicated, first because we started during the COVID vaccination campaign, and second because we had to set up the laboratory procedures for pre-vaccination screening, and a 2-test algorithm is required. Implementation is still slow, and so far 100 doses of the vaccine have been administered. Dr. Long.
Thank you. Dr. Cotton?
Dr. Chen, I have a question. If this vaccine will be available in other places, what will your recommendation be for patients that you might see in clinic who are going to live somewhere where the vaccine is available, but it's not an approved vaccine in the United States?
So the simple answer is they will not be able to obtain it it's not FDA approved. If they have that planned travel internationally, they could seek it out. It requires a lot of effort, of course, to seek it out at an international site, perhaps even at the place in which they might be temporarily emigrating to try to get that vaccine administered as early as possible. But that's really the situation. Yeah.
Any additional questions? Well, we want to thank the work group for all of your incredible work and recognize you'll go on pause, but hopefully we will be able to see this come back again one day soon. With that, we are going to take almost the full break. My members are going to be astonished. We're going to go until 55 minutes after the hour, and then we'll reconvene for our COVID-19 vaccine session. Thank you, everyone.